We are now ready to resume our session. We are very pleased to have Professor William Jack from Georgetown University that will tell us about the impact of mobile money in Kenya. So he has several works that he's going to tell us about. So please.
So good afternoon, welcome back from lunch. I hope you had some of that fake espresso coffee to keep you awake. It felt like espresso in those little cups. Thanks to the organisers for inviting me. It's a delight to be here in Portugal. I think. Yeah, I think that's it. I'm going to talk to you today briefly about some past and ongoing research in Kenya on mobile money. There's a couple of papers I'm going to kind of refer to in this talk. I won't go through them in any particular detail. One is with my colleague at MIT, Cátia Suri. I just heard from Julia that some of you have already read this paper, which is, you'll know what I'm talking about. The second one is more work in progress, and that's with Darren Griffin from NYU and my colleague at Georgetown, James Savannah. The first one is an observational study, and the second one is an RCT, hence the title of the talk, Observational and Experimental Effort. So I'm sure many of you are familiar with M-Pesa, the mobile money platform in Kenya, but let me give you a quick introduction just in case. So Kenya, as many developing countries, has a widely dispersed population, and families are often broken up and spread all over the country, mainly for employment purposes. So the problem that many Kenyans have faced for a long time is that someone who's in Nairobi, or maybe Mombasa, Kisumu, some large city, earning some money, and they want to get it home to their family. Typically, the way they would do this would be to get on a bus and take it, or maybe use some relatively expensive and inconvenient transfer service like Western Union. The dominant mobile operator in Kenya, Safaricom, at the time, initiated something called M-Pesa, which was a solution to this problem. I want to just demystify what M-Pesa is by noting that, in fact, Kenyans have figured out how to do this already before M-Pesa came along. So Safaricom, like many other mobile operators in the developing world, first of all, operate on a prepaid basis. So you don't have a line that you pay off at the end of the month, you buy credit on this line with a little scratch card. And Safaricom allows you to share that credit with anyone else who also has the same line, a line with the same company. And you can do that through some other service, some other things shared, like it. So if I lived in Nairobi, I could go along to an airtime seller to work with Safaricom, and me being a son of someone, I could buy airtime from that guy by giving him shillings. I could then send that airtime to my mother, who lived a long way away. She would get it on her phone, and then she could sell it to someone else who, by exactly the same process, sending it to them, but that was someone who lived right next door to her. And that person would give her money. So that was a way for me to get money, cash, from me to her along my way. I did it by buying something from a Safaricom agent and then using the technology to send that something to my mother, who then sold it to someone in her village, possibly just a friend or someone in the market. The price at which she sold that would have been dependent on the supply and demand conditions, and she would have to find someone who was willing to buy this stuff from her, obviously, and she may have to pay a discount. The revolution of M-Pesa had nothing to do with the technology. It was already there. The revolution of M-Pesa had everything to do with replacing the two guys at the end of that chain with an M-Pesa agent. That was someone who had the liquidity, both cash and electronic, to serve the purposes of buying and selling this cash at either end of the chain. So the first thing I think that we need to remember is that the success of the M-Pesa, which was due to many things, I think was one of the key components in that success, was the evolution of this agent network. Having people at both ends of the chain who are willing and able to either take deposits, that is, sell e-money, or allow people to make withdrawals, that is, buy the e-money back. So this is a graph, a little bit of an old graph now, of the evolution of both the customer base and the number of agents in the country. Customers are in millions on the left-hand side, and agents are in, on the right-hand side. You'll see that these co-evolved quite closely over this period. By 2011, there were roughly 25,000 or 28,000 agents. Currently, it's hard to tell, there's so many. There's about 80,000 agents in Kenya. The country of about 40 million people, and about maybe up to 2,000 bank branches now, 1,500 to 2,000 bank branches. So 80,000 M-Pesa agents. Think of those M-Pesa agents as simply human ATMs. They allow you to take money out. They're a little bit better than ATMs, and they also allow you to deposit money. But that's better. So I can show you the geographic evolution of the agent network because of a survey we did across Kenya. So in June 2007, which is 3 months after M-Pesa was launched, this is a map showing the distribution of agents. It's not all the agents, it's agents in a representative sample of districts where people live, basically, in Kenya. And over the next 3 years or so, that distribution of agents evolved as such. By the middle of 2010, it had reached roughly 25,000 or 20,000 agents. The one takeaway from this picture is that the distribution of agents did not start in Nairobi. Nairobi is in the middle here, by the way, and spread out. That would have been more or less useless early on. But they had to start spread out and then get deep. Okay? If you were going to send money from Nairobi to Kisumu, which is on Lake Victoria, you needed to have someone at the other end to do that. And so from the beginning, that network had to be widely dispersed. That's why Safaricom lost money on this for the first few years. They had to build this network before they could make any money. It's like building a bridge to nowhere, like only Sarah Palin could do. You actually need to go somewhere on the other end. Okay. So this is a map of the survey we did. We went to 3,000 households across Kenya in roughly the same areas that we looked at these agents. And we visited them 3 times over the course of about 3 years. So that's the kind of the structure of M-Pesa, if you like. And by the way, people pay to use it. There are fees associated with sending this money and retrieving it, etc. So it's not like a free thing. In the economics literature, in the development literature, it's been widely understood for a long time now that life is risky, and in the developing world, formal insurance is uncommon. Even if it's available, sometimes households are unwilling to take it up, and we see this from a number of RCTs now. But also, on just walking along the streets of Nairobi these days, you'll come across this guy who is trying to sell you insurance, and then just looking at that, you would think, why would you blame these people for not buying insurance? Okay? I mean, I'm not convinced. And insurance to many people is a very, very foreign concept. Right? People have been looking after each other for millennia in Africa, but they haven't been paying premiums into a financial institution for very long at all. The idea that you would pay someone money and maybe get something back and maybe not is a difficult concept for some people to appreciate, me included. So, in the absence of formal insurance, networks of families and friends, etc., have typically looked after each other, and there's a lot of literature showing that they do that quite well, but not perfectly. There's still residual risk left over. And the usual suspects in explaining that are complicated things that we can write down tricky mathematical models about, and called moral hazard and adverse selection, information asymmetry type of problems, and also limited commitment problems. It's hard to stay in a group if you're the one who's always lucky paying for someone else. The last one that we address in this paper is just transaction costs. If it's hard for me to give money to my mother, then I won't. Even though I trust that she's not lying. She really is sick, so there's no moral hazard problem. And I'm committed to her, like a son would be. I'm always going to be in this relationship. It's not that I have a problem sustaining this commitment. It's just hard for me to get money from me to death. If that's the case, then the only time I will do that is when she's really sick, maybe. And there'll be a lot of small bad events that go uninsured. So in this table we address the importance of this aspect, this element of incomplete insurance using the rollout of M-Pesa. So this is a picture about showing the cost structure for sending money around the country. The green line is the postal service money transfer system, the red line is Western Union, and the black line is M-Pesa. The thing that's not on this graph is the convenience and trust and everything that went along with M-Pesa as well. When you've got 80,000 agents around the place, it's really easy to drop off your money next door to wherever you are. And it's really easy for your mother to pick it up. If you had to go to the post office, then you might have to catch a bus into town to do that, but there are other costs associated with these other forms. So what are the results of our study from this experiment? I won't go through any of the metrics. So when households suffer negative shocks, let's say when bad things happen, like an illness or a crop failure or something like that, then typically people who don't have access to M-Pesa see their consumption go down by 7 to 10%. Okay? On the other hand, M-Pesa's users see no fall at all in that, 0. So effectively, M-Pesa is giving these guys full insurance. They suffer no volatility in their consumption as their income changes. Now, all of you will immediately jump up and down and say that this can't be right. There's clearly identification problems here. So we use the panel structure of our survey as well as that rollout of agents that I mentioned, I showed you graphically just a minute ago. In fact, you could argue that if that rollout of agents was in fact random, then we could use proximity to an agent as a way of kind of instrumenting, if you like, for access to M-Pesa. It turns out it wasn't quite random, but it was uncorrelated with everything we can see. So it's as good as random for our purposes. It turns out the impact on risk sharing is the same. M-Pesa users or people who are nearby agents or people who have access to M-Pesa are better able to protect themselves at risk. This has big implications, not just because people are risk averse, but because if they're insured, they actually know, and they will take different decisions about investment ex ante and hence become richer. Turns out if we look at, as I said, income shocks, when you lose your job or your crop fails, etc., then if you don't have M-Pesa, your consumption goes down. And if you do, your consumption is constant. If, on the other hand, you face some shock to your needs, typically this is a health shock, so you've got the same income coming in, but now you've got more health expenditure needs. So non-users don't see their expenditure change, but users of M-Pesa actually see their expenditure go up. And that's because they're now consuming healthcare. And they're not financing healthcare by reducing some other form of consumption. So how they do this? Well, the obvious route is that they're going to be getting money from someone else. But there are other ways in which they could be using M-Pesa to protect themselves. One is that they could just be saving on the device. Maybe it's an easy way to save, and they're self-insuring. Or maybe just because they've got access to M-Pesa, they also have access to a phone that's correlated, obviously, and maybe they know stuff that other people don't know because they've got access to this sort of information and communication. So we find that in fact it is remittances. That's what's driving this result. People are more likely to receive remittances, and they receive them more often, and they receive them in larger value if they have M-Pesa. And those remittances actually travel a longer distance. So the social network, if you like, that people have access to expands. And M-Pesa allows people to reach people further away in order to help them in that. That's a pretty, I think, robust result and a kind of a strong and, I would say, perhaps unintended result of M-Pesa. M-Pesa was certainly advertised as a way to send money home, but whether or not it was advertised as a way to reduce risk, it wasn't. Well, I don't think it was, but that's one of the outcomes that we saw. So let me move on and talk about the second paper in this brief discussion, and that's how mobile money can be used more specifically in the context of improving health. So, as I just said, remittances are an important source of typically people use this device as a way to save, or maybe as a way to commit certain resources to help by having some kind of commitment device on their phone. And the other one is simply as a way of getting money to people who we would like to redistribute to. So that's the third point, the mobile vouchers. Is there a way to use the telephone as a way to basically give out what would be food stamps in the US, but here are health vouchers of some kind in Kenya. So our specific area of interest was in maternal health, and this project was undertaken in Western Kenya, in Lake Victoria. And this picture is not about the study, it's just a correlation across countries. This is my kind of World Development Report graph, showing a correlation between, across countries, of the rate at which births are attended by a skilled attendant and the maternal mortality rate. This is over time. So basically, if you've got more, if you're more likely to have your kid with someone who knows what they're doing, then the maternal mortality rate is lower. Of course, there's no causation here to speak of. It turns out over the last 20 or so years, things have been improving. This is the rate of skilled birth attendance in the 1990s, and this is in the 2000s, and basically things have improved. Most of these dots are above the 45-degree line. Similarly, the maternal mortality rates have also improved. Again, these ones, rates in 1990, this is rates in 2010, and they're all below the 45-degree line. So people are getting better access to skilled attendance, and mothers are not dying as often in childbirth. With that very unscientific motivation, we went to Western Kenya to look at trying to increase the access of people to maternal health care services. And if there was a way of using mobile technology to do that. So the things that stop women going to the clinics are basically cost, either the cost when they get there, or the cost of getting there, and maybe their knowledge about whether or not they should go. Okay, so all of these things we thought might be susceptible to an intervention using the mobile phone, either as a means of sending money or as a means of providing information. So we did an RCT. So in this area, we basically recruited, it was a district of Western Kenya. We recruited all of the pregnant women we could find in this district over about a 6-month period. The only women who we didn't choose were people who had formal sector jobs, so people like teachers, things like that. So for some of them, we gave them a maternal health care voucher. That is, they could use this money to pay for the care when they got there. And there was a full voucher, so it was free. Some of them got a co-payment voucher, so they had to pay a little bit. And for others that were in the control group, they had to pay the full cost. Similarly, there was a transport subsidy. And it turns out the transport subsidy, I think, is more interesting. So the transport subsidy would either be an unconditional one or a conditional one, and then there was control. The unconditional transport subsidy was, I'm going to send you the money when I know you should be going to have your baby, or when I know you should be going for an antenatal care visit, that is, or a visit for the birth. We spoke to these women when we recruited them, and so we could figure out about when, about where they were in their pregnancy. The conditional transport subsidy said, when you get to the clinic, that's when I'll give you the money. Okay, so they had to get there to get the money. So this is a distribution of women in our sample. Similarly, we gave them so-called information incentives, which is just reminders that they should be going for a checkup, etc. Interestingly enough, we had two different kinds of reminders. One was a plain one that said you should be going this week for your checkup. The second type of reminders was driven by kind of people like in touch with their feminine side or whatever, who thought it would be great to tell these women about how wonderful it is to have a baby and how the baby's going inside them, and all that good stuff. And try and really contextualize the message so that it would really be more salient, and they'd really respond to that and go. Okay. So we had there's 3 by 3 by 3 lots of cells in this study. So let me tell you what. So I think our last mother has just given birth this week or something like that. So this data is just out of the oven, and so not public yet. So here's a table showing you the coefficients on, this is one regression, and the right-hand side variables are all the interactions between the two financial incentive interventions. But it's better to look at that in the picture, for me at least. People in the control group for both of the financial subsidies, who've got neither the transport nor the medical care voucher, about 30% of them went to the clinic to have their baby. And it turns out that's spot on with regard to the survey data from Western Kenya. Roughly 25 to 30% of women say they can deliver in a facility. If we give them a financial incentive, either pay them, allow them to get the medical care for free or at a subsidized rate, or get transport for free, unconditional or conditional. That rate jumps from 29% to between 60 and 75%. So that's a 2 to 2.5% increase in the number of women going to have their babies in the clinic. Interestingly enough, you only have to give them one of these subsidies to get them to go. And it doesn't matter for the transport, it doesn't matter if it's conditional or unconditional. You can just give it to the woman about when you think she needs to go, and it turns out she'll go. Now, an economist would say, if you give it to her like that, she'll use it she'll spread it out across maize and whatnot, all these things, and it's not going to have any effect on where she goes. But apparently it does, which is kind of gratifying because it means it's really easy to get women to go to the clinic to have their babies. It turns out to be kind of hard to pay for medical care. A medical care voucher, you have to have an agreement with the facility on how much it's going to cost, and what you're going to pay, and you've got to have they've got to send you an invoice saying this woman can have a baby here. Yeah, there's a whole lot of messing about just to give them some money. If we just know when the woman is supposed to have a baby, we can just send her the money by the telephone, and then she'll go. And the transaction costs involved in that are very small indeed. So I can show you a couple of other results. These are where the woman was going to go to the 4 antenatal care visits that she was supposed to go to. The WHO said that she should go to 4 antenatal care visits. Have you been to 4, by the way? They asked me to check. No, I didn't. No, I said, have you been to 4 antenatal checkups?
Oh, yes.
Yeah, okay. So it turns out that the results here are even larger, right? So it turns out 3% of women in our sample, by the time they'd given birth, had gone to 4 visits to the doctor before giving birth. Now, I'm not sure that 4 visits to the doctor is really worth it in Western Kenya, but that's what the WHO say they should do. Whereas if, you've got some of these subsidies, this one, for instance, 31% of people went. And at least 20% of people are going if they get a subsidy at one time or another. And finally, we can look at postnatal care visits, so taking a kid along to be immunised and things like this. Now the results are even more striking. The control group only 2% go, whereas people who get the subsidy is up around 20, 25, 30, 37%, depending on what kind of subsidy it is. This is very gratifying. It means we can use some kind of mobile money to get the people to go. Now, it's not the mobile money that gets them to go. It's the fact that we can use mobile money to get them money. And that's the big thing. In rural Kenya, this is a rural district of Kenya, it's a pain in the neck to take paper vouchers all over the district to people to get them to go. That's why we can just send them a simple text and they're off. Okay, last slide. I said that we also gave them the incentives, the informational incentives, reminding them to go. And especially we were smart enough to really connect the woman to her child, because that would surely have a big effect. As a man, of course, I know everything about this, right? Yeah. Don't do this at home. So it turns out there's a small effect whether or not you go through 4 ANC visits of getting a simple reminder. But in the facility, this is did you have your child in the facility? We've got some bad news. If I send you this message that really puts you in touch with this child inside you, then you're 8 percentage points less likely to go to have your kid at the facility. That's on an upper baseline. This is controlling for all the other financial incentives that I gave you. So effectively think of it as amongst people who don't get financial incentives, of whom about 30% go to the clinic to have their baby. If you get these contextualized messages, only 22% of you. So it's kind of a cautionary note, I guess, that we should think carefully about what kind of communications we use the mobile phone to deliver, and the best intentions that we may have will need to be kind of checked with a bit of reality on the ground. We don't know for sure why this is the case, so we've got an end line in the field now asking people, how they responded to the different incentives, etc. One theory is that in Western Kenya, people refer not to having a baby inside them, but to having a stone inside them, because the chance of things going wrong is sufficiently high that you don't want to get your hopes up. And all we did as Mzungu males was convince them that that was not the way thing, and what would we know? So, thanks a lot.
Okay, so thank you so much for this wonderful talk. Well, it's a topic that I've been interested in for some years, and some people here who have also been working on the topic. And so it's really a pleasure to have you here telling us about your recent work. I mean, you have more, but your recent work on the topic. So especially this case of Kenya that I think illustrates a lot the potential that Africa has for leapfrogging technologies such as, as we have cell phones, right? So we have this wonderful potential of cell phones to be used to improve the livelihoods of people, and this is exactly what Billy was telling us here. Okay, so the first paper that was telling us, we started very modestly, it had just been out in the AER. So it describes the context of the spectacular success that NPN has had in Kenya. And we know that this actually has not been replicated elsewhere. But I think it's very interesting to look at this case because it gives us the opportunity. Okay, so in other countries, in other African countries, this opportunity of cell phone technology is also trying to be used, okay, for a good purpose. But it has not reached the level of Kenya. But I guess this is the potential that we may want to achieve, and so it's very important for us to understand more about this case. Okay, so the main results that this paper tells us about is this idea that M-Pesa has contributed to risk sharing. And this might not have been the first thing you were thinking about when you heard before the whole success. Okay, so before 2010, before it was launched, maybe this was not the thing that you were expecting to achieve at first. Right, so this is, people thought this was like a method for payments, maybe for saving, but people were not perhaps putting so much hope on the role of transfers, of remittances, and this was a huge success in the Kenyan case. And this is exactly what Billy and Patrick underlined in this paper. So this idea that there is a huge success, it has you really can smooth consumption, you really can be better off when you are faced with shock because you are able to expand your network, your network of support. And so that's what they show, and they show this growth of transfers that are facilitated by the low transaction costs that this technology enables. So I think this is a wonderful paper, and one where we have seen most of the contribution, and I think it's quite inspiring in some of the work that follows, some of the work that we have also been doing. This is inspiring because this is a mechanism that I think is very promising, that should be further tested in other settings. Now, the second paper, okay, so I have my interest that is not so vested, so you can obviously see it. So this paper on how can this wonderful technology, how can mobile money be used for other purposes. Okay, so we have the technology again. We have this widespread technology in Africa that is cell phone technology. How can we use it for different purposes to improve the livelihoods of people? And so, what we have here, the main objective for this work, is to evaluate how cell phone usage, both mobile money and also information exchange using SMSs, can improve maternal health. Okay, and I should thank you very much for sharing with us the results of this work and with me in advance, because as you were saying, they are so collected that the last set was collected this month. Okay, so moms were giving birth this month, and it is already there. So thank you so much also for that. And here actually, I mean, basically this intervention, this randomized intervention, looks at different incentives that mothers could have to improve their maternal health, and that could be delivered, through cell phone usage. Okay, so first of all is financial incentive. And here we have two types of financial incentives that were tested for, which were the costs of health consultations themselves, and also transportation costs, which are not trivial here because we are talking about rural locations where presumably this would be important. And indeed, those are the results that are obtained here. And on the other hand, you could also think that maybe these pregnant women are not attending health consultations, both before and after the baby is delivered, just because they are not really so tuned into what it is to be pregnant and to be expecting the baby. And so this was another hypothesis that this intervention showed. So I think these are interesting questions. I hope it's not only me. I suspect some more of you will be also interested. And the results are quite interesting, I thought. So first of all, we have that financial incentives, okay, both types of financial incentives, both the cost of consultation and transportation costs, do seem to improve maternal health. So this is something that is very important. And again, here, so I think what is really nice about Web is that it shows that mobile money can be used also for other purposes. So this is a technology that, this payment side, or this real transfer, can be used for these effects. And so both types of incentives seem to be effective, although conditional transport vouchers were more effective, at least for postnatal care. And this was interesting, I thought. Information incentives do not seem as effective. So let me think here a bit, and I'll have very few comments, but just a few comments and questions about, so let's to think about what is happening here. Okay, so one thing that I was not sure, but Billy has now already answered is, like, okay, who are we targeting here? Okay, so which kind of women are we? Are we having here in the intervention? How were they chosen? So this, I think, is also important for us to understand. The bill has already said, so these are mostly women in rural West Kenya. Okay? So one thing that I thought was, so who owns the cell phones? Okay? Is it the women or is it, say, the husbands? Okay? So if that's the case, it would be that the husbands would be filtering both the financial incentives and the SMS information. So, this could be a reason for conditional transport vouchers to be more effective than the unconditional ones, okay? Because otherwise they'll just keep the money. But it could be the same thing for information. Maybe the husband, okay, here, well, some are more in tune, some are less, but maybe these husbands could be less tuned to this information, and they would filter it out, and hence this would not go through. Although you have a result that is different between treatment and control, but this could be a reason for it not to be so strong. And then, in terms of the region where these women are based, and basically what's the effect of age and coverage here, I think this is also important for us to understand exactly what's the setting, what are the implications that we can. And here, what I was thinking is, so we always want to. We always tend to think about the work that we are doing parallel to this. And what I was thinking is, so here we are thinking about a setting where there is potential for this to work, and that's very good, and you showed that it worked. Now, what about other settings? And so some of the work that the NOVAFRICA Center has been doing has been on mobile money in Mozambique. Okay? It's totally different setting. When we started doing this work, basically the service had not been launched in the country. And this is a country where, financial services are very limited in rural areas. Okay? We have heard a bit about today about Angola and Mozambique and how financial services are developing, but we should underline that this is only for the capital cities. Okay, so both in Angola, both in Mozambique, what you see is that yes, you have quite some development in the capital cities, but you have none outside. And so if we think about rural areas in Mozambique, for instance, you have only 1.3% of the adult rural population using formal savings from it. Okay, so just compare with the average 20% for the sub-Saharan Africa, which is still low, but we are talking about countries here where it's really, really very limited. And in terms of formal money transfers, which is the thing that's, okay, mobile money, you have shown, has been able to really change. Okay, what we see is that formal money transfers are using less than 20% as the transfers that are here. So this is a different setting, totally different. Okay, and even it's different from other countries where mobile money has been launched and has been spreading, not as successful in Kenya for sure, but has been somewhat spreading, like Uganda or Kenya. So here, the opportunity we saw here was to do these experiments where we were randomly introduced to service, right? And basically in rural locations that have the characteristics that I've just described. So this is a different setting, and I think this work is complementary in the sense that, okay, so we saw like the potential, okay, that there are good things to be attained, but are they attainable in other settings? Particularly settings that are very disadvantaged in terms of financial inclusion, such as Mozambique. Okay, and so what we do here, and I want to present my homework. Okay, so this is just a small discussion, just to relate a bit to what Bill was presenting. But basically, what we did here was, first of all, to go to the rural areas. Okay, so the places where I know that no financial services available are the rural. So that's what really started by disseminating the service. And then, because we learned from even earlier work that these remittances, this channel for remittance was so important, so we decided to also target urban migrants, so the family members for these families in rural areas, in basically Maputo, right? So that's a big migration corridor that you have. And so we have been following them over time. We don't have, we are still analyzing, we just have some results on it. I'm going to give you the short version, but basically what we see is that people really, they adhere to the services, okay? So we have basically 60% of people, okay, which is a high number, 60% of people conducting at least one transaction in the 12 months after we were there, and this is a nice number if you compare to these other countries that I was referring to, like Ghana or Uganda, where basically you have rates of 8% of people. Obviously, these are not our cities. Maybe we did a bigger effort at the dissemination, but just to say that this is 66% of people using is something that we were quite happy with. And then we have some evidence that people tended to use cash, which is the mobile money service that you have available in Mozambique, to substitute for this traditional, unreliable remittance and savings channel. Okay, so remittances again here seem to be the most promising channel according to the administrative data that we have. And here I think, so the contribution that we have in terms of the research we are doing is this idea that we were able, because the effect was not as explosive as in Kenya, that we were able to randomize where we okay, so these are results from randomized food experiments. Okay, our idea here is to tell you a bit of other areas that I think can be interesting and can basically deliver some good promise of mobile money. Okay, so other areas are areas that we are working on. There are others that Bill is working on and others. But basically, so as I said, this is ongoing research. We have been focusing on trying to understand what makes migrants use all over. 80% of the residents do not use any sort of formal financial service. So there's huge potential. So we've been working on with these micro entrepreneurs and basically offering them a way to save. While on the other hand, this is another RCP. On the other hand, we give them some financial literacy, some basic management skills, and we try to put it together to see whether we are able to improve also this sort of, and to promote this sort of micro-enterprise development. And finally, and I'm really finishing, we have also been using mobile money to promote agricultural organization. Again, here the issue is that you see farmers, they have their crops, they sell them when they have a surplus, and they spend it. And so when the next season comes and they need to buy corn seeds, they need to buy fertilizers, they do not have the resources to do this. Okay? So if they have some sort of commitment behind. Okay, here the hope is that mobile money is the way, basically, for them to have a way to save and at the same time to benefit from some privacy. Okay? I mean, both, as we were mentioning, this idea, right? So basically here, so this is another project in which we have been working. So just to summarize, so I think, yeah, I believe there is lots of potential to create what we do. Let me just, not these. Okay, I was hoping to have a photo here. Sorry. This should not be, no, this is a video presentation. I thought I sent the last version, but I just want to show you, sorry. Okay, but just to conclude, so yeah, the idea is that I think, as Billy showed, in Kenya there was, here and Mr. Walters had shown, of course not this, but here you can see some, I wanted some photos of our staff, which is the staff that is around here that has worked in the project. But, okay, so this is just to whet your appetite. So this is the more, but just to conclude then. Basically, I think that Billy's work and co-authors has shown the tremendous potential that mobile money has been already delivering in such a huge success as Kenya. Okay? And I think other countries are trying to pursue this. I think there is work to be done in terms of research, trying to understand better what is really the potential that we have here. How can it be used in other contexts that are not as successful as Kenya? Okay, and our work that I showed you is a part of that, but I know there are many more. So yeah, that was my kind of brief comments on the topic. Okay, so I think now we'll take some questions from the audience.
Thank you. The women selected, do you know whether they were literate, which languages they use in the communications, and you know whether the literacy had any, caused any differentiation in terms of the impact?
So we use Swahili for our communication. Swahili tends to be translating from English to Swahili, the number of letters seems to go up by 50%. So getting these texts into 140 characters was a challenge, but we did. Now we had some survey data, which I didn't present here. All of this was kind of, survey data is just on the survey data we have on household characteristics I haven't included in here, and I really haven't included it yet. But there'll be stuff in there about education for sure. So, yeah, we'll need to look at that. That could be the reason that the text didn't have as much impact as we might have thought. Although the fact that there was this negative effect is really kind of puzzling. I should say also that I think you asked the ownership of phones was not that widespread, but it turned out a lot of our women actually, because we recruited our women by working with the community health workers who are also women in the villages whose job it is to basically check up on health status of people on a regular basis. And they tend to know who's pregnant. And so we went through them to recruit these women. It turns out that quite a few of the women actually just used the community health worker as, if you like, the M-Pesa agent. So they would give us her phone number as the one for whom we should be sending money. And it seemed to work reasonably well. The husband is also often the owner of the phone, or the custodian of the phone, so they can have it for us.
Okay. Some more questions? Well, otherwise, we'll keep talking. Maybe now. Yes.
Yeah. So I was just interested in the health voucher experiment and thinking about. Basically what it looks like the results are is that there's kind of this high sensitivity to getting any kind of a discount at all. And there's less sensitivity to getting something for free. Maybe I'm misinterpreting it, but so do you think that some of that is due to maybe a discount effect or some kind of like, instead of thinking about it as a price and thinking about it as, well, am I willing to go if it's free or am I willing to go if it's some on price. It's more, am I willing to go if I get any discount at all? Because it's a little hard to think about what kind of a demand model would produce a result like that.
So I think we actually see the deliveries are higher for most people who go for free, and they're a little bit low, but still high for people who have to pay 100 shillings, which is about €1 for the delivery. And for people who have to pay the full price, which was principally some was about €10, the demand is much lower. What we don't see is this discontinuity at zero, which I think you're referring to. I don't see that as a puzzle. I mean, I think the discontinuity at zero is something of a puzzle. Here, I think you line up these 3 points, you get it down to second market. Although I guess the first 2 points, where you're paying over $0, $100, they're too close together in terms of the prices to tell us much about the overall shape of the market. But it seems to be consistent with